Hi, everybody. It's past 1 o'clock. And so to try to stay on time and get everybody out also on time, right in time for rush traffic hour, I'd like to start the afternoon session. So our first speaker is going to be via Zoom. She's not able to be here in person today. Dr. Aziz from Stanford is going to be talking to us about immunizations and pregnancy. And hopefully technology is going to cooperate. Yes, there she is.
Thank you, Dr. Salinov, and good afternoon. It's a great pleasure to be here to discuss immunizations in pregnancy with a review of current recommendations. To begin, I have no industry or other financial disclosures. Today, we'll cover why pregnancy is an amazing opportunity for immunization. We'll follow it with general safety principles and then the routine immunizations that are used in pregnancy, and then those immunizations to avoid in pregnancy. We'll also discuss special circumstances, including pre-exposure and post-exposure prophylaxis, as well as immunoglobulins. And then finally, we'll round up with postpartum immunizations and preconception immunizations and a couple of special cases that illustrate how valuable pregnancy and immunizations are. So given that approximately 3.6 million live births occur each year in the United States, and greater than 98% of patients have at least one prenatal visit, healthcare is a huge opportunity for vaccination, and immunization is effective in pregnant patients. It provides infectious protection for the pregnant patient, the fetus, the neonate, and even the young infant. So the recommendation from a provider is the single most important factor for vaccination uptake in pregnancy. One of the very important studies that was illustrated in Australia was that pregnant patients, if receiving a recommendation from their provider, were 20-fold more likely to accept influenza vaccine and 7 times more likely to accept pertussis vaccine. Additionally, a United States study demonstrated that 68% of women who would express concerns about their safety of their baby associated with vaccination would agree to have accepted the vaccine if their healthcare provider had recommended it. So once again, pregnancy is an amazing opportunity for immunization, and provider recommendation is very important. Historically, pregnant patients have been in a lower category for immunization for influenza, for example, including the 1990s and in the 2000s. However, with H1N1 in 2009 to 2010, there was a sharp increase in immunizations for pregnant patients. And we see that from 2014 all the way through most currently 2023 to 2024. And there was again an up spike in immunization for influenza in 2019 to 2020 with COVID-19. This is a very important slide in that it shows pregnant patients being in somewhat a lower category amongst the higher risk patients for immunization. And we see here that since 2019, 2020, there's been a steady decline in influenza vaccination in pregnancy. So something very important to keep in mind. When we look at Tdap vaccines have generally stayed above 50% and ranging between 55 to 59% over the past 5 years or so. And again, inactivated influenza, with another study that showed that it was as high as 60% during pregnancy, during COVID, first year of COVID, we see that the most recent studies show that it's decreasing to about 38% with some preliminary studies from 2024 to 2025 by the CDC. We do know that the acceptance rate is highest when the provider refers and offers the vaccine. So influenza was accepted 75% of the time and Tdap 72% of the time in 2022 to 23 when the provider referred or offered the vaccine. And we know that the lowest rates are in Black and Hispanic pregnant individuals. So again, very important to keep that in mind. And the lowest in non-Hispanic Black pregnant women, which was 26% in the 24-25 influenza vaccine season. With respect to COVID-19, generally the numbers stay around 30% since the COVID epidemic and pandemic occurred. And with RSV, the rates are generally 30 to 38% since the last 2 seasons that it's been introduced. So general safety principles include type of vaccination, timing and trimesters, autism association, and then thimerosal and adjuvants and their safety. Well, from an obstetric standpoint, immunizations may be separated into 2 groups: inactivated or killed vaccines, toxoids and immune globulins, which have no evidence of harmful effects on the fetus in pregnancy, and they're considered safe in pregnancy. And the other group would be live attenuated vaccines, which have a theoretic risk of infecting the fetus. Generally, though, no teratogenicity or classic congenital infections have been reported for the most part. There are subclinical infections reported and a very rare case report, which I'll discuss later. However, nonetheless, their use is discouraged during pregnancy unless there's high risk. And administration during or within 4 weeks of pregnancy, because of the lack of congenital infection, does not warrant termination. We counsel patients about potential theoretic risks and the lack of cases demonstrating harmful effects to the fetus. With respect to timing, inactivated virus vaccines, toxoids, and immune globulins can be given at any gestational age, and that includes first trimester. It's really, you take into consideration the special risk to the unimmunized pregnant patient, fetus, and newborn. That's important versus timing a gestational age for organogenesis. And we do know that vaccines in the later trimesters are more effective to optimize the transfer of antibodies to the fetus for benefit in neonatal period in such vaccines like Tdap and RSV. Well, for all of the data that's occurred and the decades of studies that have been looking at this, we can with certainty say that epidemiologic evidence does not support an association between immunizations and autism, and it's as simple as that. Thimerosal is a mercury preservative used in vaccines, and there's no evidence that thimerosal-containing vaccines cause adverse effects like autism in offspring of patients who receive these vaccines during pregnancy. Nonetheless, in 2006, a California law actually prevents pregnant women and children under the age of 3 from getting thimerosal in their vaccines. And adjuvants are used to enhance individuals' response to vaccine, and insoluble aluminum salts like aluminum sulfate have good safety profiles and are used commonly in pregnancy vaccinations. Newer adjuvants lack safety data and therefore are more avoided in pregnancy. Some of the important immunization considerations to also think about is that immunizations can be administered at multiple vaccines at the same time. So it's very easy to vaccinate your patient with COVID and influenza vaccine on the same day, for example. Anti-D immune globulin, or RhoGAM, does not generally reduce the response to MMR or varicella vaccines when administered postpartum. However, we do consider serologic testing 6 to 8 weeks after vaccination, given the fact that it is an antibody. Passive immunization to the fetus is served through maternal IgG antibody that crosses the placenta and maternal IgA antibody that's transferred through the breast milk. Now I'd like to focus on the 4 immunizations that are used most often in pregnancy, and they include Tdap, inactivated influenza, COVID, and RSV. So with Tdap, or tetanus, diphtheria, pertussis, acellular pertussis vaccine in pregnancy, the indication is all pregnant women during each pregnancy, regardless of previous immunization history. So if you've had Tdap before in the past, that does not contraindicate for you to get the vaccine again. We recommend it with each pregnancy. Timing is ideally between 27 to 36 weeks of gestation, and more studies show that there's better immune response generally during the earlier part of this period, although there is some conflicting whether it should be given earlier or later in this period. And you do not have to repeat Tdap if it was administered earlier in the pregnancy for purposes of tetanus, for example. And if a patient declines Tdap during pregnancy, postpartum can be administered if the decline was during pregnancy. The dose is a single dose series. The tetanus and diphtheria are toxoids, and acellular pertussis is the inactivated vaccine. It's also recommended for individuals like partners, family members, and childcare providers who are expected to have close contact with a newborn or young infant who's younger than 12 months of age and have not received their Tdap previously. So if somebody has not received an adult Tdap vaccine, it is recommended that if they have contact with an infant up to 12 months of age, that they receive a one-time single dose of adult Tdap. Pregnant women, though, as a reminder, are the only population in whom repeated Tdap immunization is recommended. With respect to rationale and safety, the prevalence of pertussis in the U.S. has been increasing over the last several decades. Immunity after vaccination or disease wanes over time. Adults who develop pertussis can transmit the disease to susceptible infants, especially those infants that are less than 3 months of age or at the highest risk of morbidity and mortality. And amazingly, 50% of infants with pertussis contract the disease from family members, mostly their mothers. And fortunately, we have evidence to show that there's no increase in significant adverse maternal, infant, or pregnancy outcomes. With respect to efficacy, maternal vaccination during pregnancy decreases infant risk of pertussis. There's direct protection to decrease exposure risk, or also known as cocooning. And then the passive protection through antibody transfer through placenta and breastfeeding occurs. And this all leads to Tdap vaccination at 27 to 36 weeks of gestation was actually 85% more effective than postpartum vaccination at preventing pertussis in infants of less than 8 weeks of age. So if a patient wants to decline her pertussis vaccine, I always bring up this study to say that the baby will have better protection if the pregnant patient receives her vaccine during pregnancy. Infants with pertussis whose mothers received Tdap vaccine during pregnancy also had significantly lower risk of hospitalization and intensive care unit admission and shorter hospital stays. Maternal Tdap vaccination was also highly protective against infant pertussis, especially in the first 2 months of life. And this additional protection from maternal Tdap vaccination is also seen for the first year after life, even after receiving DTaP at 2 months of age. So the next one of the most commonly used vaccines is inactivated influenza. With respect to indication, it includes all pregnant patients who are either pregnant at the time or postpartum or lactating. It's generally administered during September so that we are prepared for October through May of influenza season. It's administered in any trimester because it is for the protection of the pregnant patient as well as the infant. It's a single dose series. Infection is associated with morbid infection during pregnancy, and pregnancy is a severe risk factor for worsening disease. So the use of inactivated vaccine for pregnant women is very important, and there's no adverse effects or pregnancy outcomes, fortunately. Now, there are 2 types of influenza vaccine, the inactivated and the live attenuated. And we do not recommend the live attenuated in pregnant individuals. We only recommend the inactivated influenza. And as a reminder, influenza vaccine in California is thimerosal free for pregnant women and children under the age of 3. So inactivated influenza, the efficacy reduces maternal influenza illness and hospitalizations. For example, in H1N1, vaccines reduce the risk of influenza-like illness in pregnant patients by 89%. Seasonal vaccine reduced the risk of influenza-like illness in pregnant patients by 24%, and adjusted influenza vaccine effectiveness was 40% against influenza-associated hospitalizations during pregnancy. The next efficacy point is that it improves pregnancy outcomes. There is reduced risk of stillbirth of 0.73 relative risk. There's reduced risk of small for gestational age infants and preterm deliveries, and there is increased birth weight in those patients who receive the influenza vaccine. And finally, for efficacy, we have the protection of infants for several months after birth. So antenatal maternal immunization induces substantial levels of influenza-specific IgG, which is actively transferred across the placenta to the fetus from the mother. Anti-influenza specific IgA is also found in breast milk, which is transferred to the infant during lactation. Newborns of vaccinated patients had a 41% reduction in laboratory confirmed influenza in one study, and similarly a 34% reduction of laboratory confirmed influenza among a second study. So the next vaccine that we, again, routinely recommend during pregnancy is the respiratory syncytial virus, which is the newest comer of these four. The indication is all pregnant patients to be vaccinated from September 1st through January 31st in preparation for RSV season. The timing is 32 to 36 and 6 days. Dosing should be a single dose series. Second dose in subsequent pregnancy is not yet recommended. There are several studies now being conducted to assess if this is something that should be recommended, and these studies are in progress. RSV is a major cause of morbidity. It includes bronchiolitis, apnea, and mortality in infants. And the inactivated non-adjuvant recombinant RSV vaccine, Abrysvo, has been approved by the FDA for use in pregnancy. It reduces the risk of severe RSV bronchiolitis in infants if maternal administration occurs at least 14 days before birth, allowing the mother to produce the antibodies that then cross the placenta and also are contained in breast milk. An alternative strategy to the vaccine, if it's available, is immunoprophylaxis of the newborn with anti-RSV monoclonal antibody, nirsevimab. So, and how the FDA and ACIP recommend is that there should be a joint decision-making process when both the vaccine and the anti-RSV monoclonal antibody are available for the patient. So safety, there was only the report of preterm birth of less than 37 weeks was slightly higher in the vaccinated group of 5.1% versus 5.9%. However, that confidence interval did cross 1, and so the difference wasn't statistically significant. And preterm birth was really below the expected rate of 10% worldwide. So it was an interesting but perhaps an aberrant result. There was no difference of rates of congenital abnormalities, intrauterine growth restriction, or stillbirth with the use of RSV vaccine in pregnancy. And with respect to efficacy, infants born to mothers vaccinated with a maternal RSV vaccine in a systematic review, including the RSV pre-F, which is used in the United States, had fewer hospitalizations for laboratory confirmed RSV disease within the first 180 days after birth compared with placebo. They looked at nearly 18,000 pregnant individuals who had been vaccinated, and it showed that there was about 11 versus 22 hospitalizations per 1,000 infant risk ratio of about 0.5. And finally, the final vaccine that we generally recommend for pregnancy in all pregnant patients, as well as those who are postpartum and lactating persons, is COVID-19 and during the respiratory season. The timing is any trimester. Dosing is single dose. It is a severe acute respiratory syndrome coronavirus 2 SARS-CoV updated vaccine booster for this year. Vaccination is safe and effective at preventing coronavirus disease of 2019 in pregnant and breastfeeding patients, and it reduces the severity of disease if a breakthrough infection does occur. The rationale is that pregnant and recently pregnant people are a group at higher risk for severe COVID-19. Pregnancy itself is associated with increased risk of severe infection, and the safety is tremendous. There's no evidence of harmful effects on fertility, assisted reproduction outcome, embryo or fetal development, pregnancy outcome, parturition, or short-term postnatal development of offspring. There was a systematic review that looked at over 170 studies with greater than 630,000 participants in over 41 countries that showed no difference in all assessed maternal and infant outcomes, regardless of the trimester of exposure to COVID-19 during pregnancy. With respect to efficacy, pregnant patients have reductions in severe COVID-19 or hospitalization from 22 to 53 fewer per 1,000 vaccinated pregnant persons. There was a reduction in symptomatic COVID-19 in infected pregnant persons, 31 to 130 fewer cases per 1,000 vaccinated pregnant persons. And there were also statistically significant reduction in stillbirth of 1 fewer per 1,000 vaccinated pregnant person. Efficacy for infants in this Chia Pony study revealed that there was severe COVID-19 or hospitalization due to COVID-19 in infants up to 6 months of age. That was 188 to 194 fewer per 1,000 infants of vaccinated mothers. Laboratory confirmed SARS-CoV-2 infection in infants up to 6 months of age was also 70 fewer per 1,000 infant of vaccinated pregnant persons. There was also more efficacy of infants that was demonstrated in a study by Halassa and colleagues, which demonstrated that COVID-19 vaccination series during pregnancy was associated with a reduction of risk of COVID-19 hospitalization among infants of less than 6 months of age, with a vaccine efficacy of 52%. Vaccine efficacy against admission to an ICU for COVID-19 of those whose pregnant parents were vaccinated included 70% efficacy. 90% of infants admitted to the ICU for COVID-19 were born to mothers who were unvaccinated. And the only 2 infants who died in this study were born to unvaccinated mothers. Now, one of the biggest shocks of our respiratory viral season recommendations was when the CDC did not recommend COVID-19 vaccines for healthy pregnant women. And shortly thereafter, both ACOG, which is the American College of Obstetricians and Gynecologists, and the Society of Maternal Fetal Medicine, which are our guiding groups in obstetrics and gynecology, both released statements stating that COVID-19 was highly still recommended for pregnant patients during this respiratory season for the aforementioned reasons and efficacy. So immunizations to avoid in pregnancy include those that are live attenuated, which include MMR, varicella, MMRV, live attenuated influenza vaccine, and tuberculosis. And then also 2 inactivated vaccines, which include HPV and zoster Shingrix, which lack safety data. For special circumstances, including pre-exposure prophylaxis, we have pneumococcal, H influenza, meningococcal, hepatitis A and B, Vaccinia vaccine for Mpox, and then for more traveling indications, yellow fever, poliovirus inactivated, typhoid, rabies, and Japanese encephalitis vaccines all may be given for PrEP in pregnant individuals. For post-exposure prophylaxis, hepatitis A and B vaccines, as well as tetanus, toxoid, and rabies, and for extenuating circumstances and high-risk exposures, smallpox vaccine and anthrax may also be administered in pregnancy in these special high-risk situations. Very briefly, I'd like to look at the vaccines that are used in pre-exposure prophylaxis. So pneumococcal is recommended for high-risk individuals who are pregnant who have the following chronic diseases or immunocompromised states, including cardiovascular disease, pulmonary disease, diabetes mellitus, smokers, alcoholism, chronic liver disease, HIV, chronic renal disease, malignancy, immunosuppression of other types, asplenia, nephrotic syndrome, as well as CSF leaks, cochlear implants, and chronic care facility individuals. The vaccine that has most recently entered the stage is PCV21, and it's very advantageous since it does not require a booster. Timing can be preconception, pregnancy, or postpartum. Dosing is a single series. It's an inactivated vaccine. We do not have any reported adverse events associated with this vaccine during pregnancy. The next PrEP vaccine is meningococcal, and again, for high-risk pregnant individuals who are immunocompromised or have increased risk of exposure. So this would include asplenia, sickle cell disease, HIV, complement component deficiency, C5 inhibitor use, or travel to endemic regions like sub-Saharan Africa. Those military recruits or college freshmen in dorms who are unimmunized or underimmunized when there's outbreaks, and then additionally when there's occupational exposure. The timing, once again, can be preconception, pregnancy, and postpartum. Vaccine and dosing, there are two that are required. The meningococcal MENACWY, which is 2 doses 8 weeks apart, and then every 5 years if the risk persists. And then also meningococcal serogroup B, which includes 3 doses at 0, 1 to 2 months, and 6 months, and also needed after a year after completing the primary series and every 2 to 3 years thereafter if the risk persists. It's an inactivated vaccine, and so far there are no reported adverse events in pregnancy. Our next PrEP vaccine is hepatitis A, and it can be done if completing Hep A vaccination, post-exposure prophylaxis, or a high risk for acquiring an infection. For example, in my hepatitis B infected patients, if they are Hep A non-immune, I will vaccinate them with Hep A during pregnancy. So timing, it can be any time during pregnancy. It's a 2-dose series from 0 to 6 to 12 months or 0 to 6 to 18 months, depending on the vaccine that's chosen. It's an inactivated vaccine used for both pre-exposure and post-exposure prophylaxis. Generally, pre-vaccination testing is recommended, but post-vaccination testing is not recommended since it's highly effective. And again, no adverse fetal effects or pregnancy outcomes have been reported with Hep A vaccination during pregnancy. The next vaccine is hepatitis B. So again, similar to Hep A, it can be used if you're completing a Hep B vaccination series, if there's chronic liver disease, or someone is at high risk for acquiring the infection. Timing is pregnancy. It's a 3-dose series at 0, 1, and 6 months. It's an inactivated vaccine, and fortunately, once again, no adverse fetal effects or pregnancy outcomes have been statistically associated with this vaccination during pregnancy. The efficacy in one study was interesting. After 3 doses, efficacy is at least greater than 80% in the general population based on studies. In pregnant persons, after 2 doses, it was only 49% effective. And these were immunocompetent patients versus 59 to 70% in non-pregnant individuals. So factors associated with failure to seroconvert in pregnancy included smoking, higher BMI, and older age. Pre-vaccination testing is now recommended during pregnancy as routine prenatal care. So anyone who does not have their Hep B status known, we test with anti-Hep B core antibody, surface antigen, and surface antibody. It's the cost efficacy is actually substantial if there's a prevalence of greater than 20% in the community. Post-vaccination testing for certain groups or revaccination as needed is recommended. For example, in your immunocompromised cohorts, especially since double dosing is recommended, since immunocompromised individuals may not be as effective with a routine dose. So we double the dose in immunocompromised individuals. Next, I wanted to very briefly talk about immune globulins, which are considered safe in pregnancy. And those include post-exposure prophylaxis in pregnancy for Hep A and B, for measles, rabies, tetanus, and varicella. And I wanted to focus both on measles and varicella since they are widely commonly heard of in the public health arena recently. So measles can be used for post-exposure prophylaxis. It's recommended in pregnancy. We would use immune globulin IV. It's up to within 6 days of exposure, 400 milligrams per kilogram, and it's recommended in non-immune individuals should receive the MMR vaccine no longer when they are immunocompromised or pregnant at least 6 to 8 months after getting their IVIG. So generally, if a pregnant patient needs post-exposure prophylaxis for measles, she or they would get the immune globulin, and then 6 to 8 months afterwards would receive the vaccination, since the immune globulin will wane in terms of its immunity. Varicella post-exposure prophylaxis is also recommended in pregnancy, and we have Varizig currently, which is a purified human immune globulin you administer within 96 hours of exposure, and maximum dose is 625 units IM or 5 vials. Next, I wanted to very briefly go over preconception and postpartum immunization, which includes both HPV, MMR, and varicella. For human papillomavirus, the indication is any person aged 9 to 26 years old, and if they have a future risk of HPV exposure or acquisition, those who are 27 to 45 years old. This can be administered pre-conception and postpartum, so it's not recommended during pregnancy. It's a 3-dose series. A 9-valent vaccine is the only HPV vaccine available in the United States. Interestingly, it's a category B, as animal studies at extremely high human doses have showed no impaired fertility or fetal harm in animal studies. Human studies are limited, so usually we delay the series during pregnancy. But so far in the registry, there's no difference in congenital anomalies or miscarriages in vaccine-exposed pregnancies. So again, we do not use this due to lack of data, but it is a category B vaccine. Next is measles, mumps, and rubella. So we would vaccinate if there's no indication of rubella immunity, which is something that we check in all pregnant patients at their routine prenatal visit. At initiation of care. Immunity is generally determined by antibody titer, and immunity for measles and mumps we do not need at this time. Even with the measles outbreaks that have been occurring, we still are not recommending measles immunity assessment in pregnant patients at this time, based on California Department of Public Health and CDC most current updated recommendations. Timing is preconception and postpartum. It's a single dose in low-risk individuals and 2-dose in high-risk individuals. And we want to give MMR versus rubella. It's at 0 and 1 month for high-risk individuals to rubella, mumps, and measles. It's a live attenuated vaccine. We feel that immunity to rubella probably lasts up to 15 years, but not lifelong. Measles, we think, is 99% lifelong, and mumps 75 to 95% up to 30 years. With respect to live attenuated vaccines, we really have a dearth of data showing that there's congenital anomalies, but there is a single case of a rubella congenital defect that was reported in an offspring of a woman who was vaccinated just peri or pre-conception or during her pregnancy. It was unknown at what time she conceived, but this is the single case of a congenital anomaly associated with a live attenuated vaccine that we have to date in literature searches. We still recommend avoiding conception for 28 days after administration, but again, use in pregnancy is not recommended, but termination is also not recommended in inadvertent exposure, given the very, 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 very low likelihood of congenital infection. And finally, varicella. Indication is no evidence to immunity to varicella, and as determined by your IgG antibody or vaccination documentation or clinical history of verification that you had varicella that was documented in your medical records. Timing is preconception and postpartum. Dosing is a 2-dose series at 0 and at 4 to 8 weeks. It is a live attenuated vaccine, so again, it is not administered during pregnancy for the theoretic risk of congenital infection. However, no varicella congenital defects have been reported in offspring of women vaccinated before or during pregnancy to date. And immunization of close contacts of pregnant women is safe. We just want to avoid conception for 28 days after administration, and the use in pregnancy is not recommended again, but if it does happen inadvertently, termination is certainly not recommended. And zoster vaccine is also not recommended in pregnancy, whether it be live or inactivated. So I just want to go over a couple of special cases that have actually recently just happened in my clinical practice that I'd like to show the utility of pregnancy and immunization going so hand in hand with each other. So most recently, we had 2 patients with severe ITP who were refractory to medical management and needed splenectomies that were pregnant. And so the indication was splenectomy, and timing can be preconception, pregnancy, and postpartum. And our 2 patients were both pregnant. And ideally, you want to complete the vaccines 14 days prior to the procedure so that enough antibody has built up at the time of splenectomy, or to start 14 days after the procedure. Vaccines and dosing included for these patients that we had specifically in our clinic, the pneumococcal vaccine, PCV21, which was a single dose, H flu type B, single dose inactivated, the meningococcal, MENACWY, 2 doses 8 weeks apart and every 5 years thereafter, the meningococcal serogroup B, and this was 3 doses at 0, 1 to 2, and 6 months, and then a year after, and then every 2 to 3 years thereafter, and then influenza and COVID annually. And of course, these patients will also be candidates for the RSV vaccine, as well as the Tdap vaccine in the 3rd trimesters as deemed appropriate based on their gestational ages and the RSV season. And these are all inactivated vaccines. So for our immunocompromised or HIV pregnant patients that I see very commonly in our patient population, we have our routine pregnancy recommendations for influenza, Tdap, RSV, and COVID-19. Routinely recommend hepatitis A, B, pneumococcal, and meningococcal. For hepatitis B, because the efficacy isn't as great in immunocompromised, we either double dose the hepatitis B vaccine or use Engerix, which promotes a higher immune response at 0, 1, 2, and 6 months. H-flu is not recommended for HIV positive pregnant patients, unlike splenectomy, in which it is. We do not use live attenuated vaccines in pregnancy, but they may be used in postpartum, even in HIV immunocompromised patients, unless they're severely immunocompromised and their CD4 count is less than 200. And one other cautionary piece of advice would be to really assess if a vaccine is needed very late in the 3rd trimester or if it can be postponed to the postpartum period. For example, if it's hepatitis A, B, pneumococcal, or meningococcal, because there can be a possible viral load increase. So if there's a patient who's at risk for viral load increase or already has low-level viremia, we would be cautious to vaccinate them very near the time of delivery for purposes of perinatal prevention of HIV. So in summary, inactivated vaccines are safe for use in pregnancy. Live attenuated vaccines should be avoided in pregnancy, although there is really little or no data demonstrating harm to the fetus, and termination is absolutely not recommended for inadvertent exposure. The live attenuated vaccines are generally reserved for preconception and postpartum immunization. The inactivated vaccines may be administered at any trimester. Vaccinations, live attenuated and inactivated, are generally safe during the postpartum and breastfeeding periods. And studies do not demonstrate an association between vaccinations, thimerosal, and autism or other diseases through decades of research and significant epidemiologic data. So additionally, pulmonary and immunologic physiologic changes increase the severity of respiratory disease in pregnant patients. Immunizations during pregnancy help decrease disease and complications severity in affected pregnant patients. Immunizations during pregnancy generate maternal IgG, which crosses the placenta, and generate maternal IgA, which is present in breast milk and can offer infant protection. Immunizations during pregnancy provide the newborn with passive immunity for several months after birth, thereby decreasing respiratory disease and severe complications in the infant. Finally, summary of vaccinia and anthrax vaccine may be reserved for emergency indications during pregnancy or breastfeeding. There's numerous PrEP and PEP vaccines and immunoglobulins that are safe for use during pregnancy and breastfeeding for various indications. And just as a reminder, our immunization rates for influenza, although much better than the early 90s and 2000s, as well as for Tdap, RSV, and COVID-19, still fall short of our target levels. And I urge you to remember that the recommendation from and vaccination offer by you, the provider, is one of the single most important factors for vaccination uptake and pregnancy. So I'd like to leave you with that message. There's also some accompanying slides at the end, which reviewed some of the travel vaccines. Wanted to thank Dr. Salinave as well as her team at the San Mateo County Department of Public Health and the Stanford Center for Continuing Medical Education for arranging and helping coordinate this program. And I wanted to thank you all. And I have my cell phone there, and you may use it anytime you need for any questions that may come up with pregnancy and infectious diseases or immunization. There are some immunization resources, although some of the sites are now no longer existent. So I think we need to be judicious with what we do look at. Current vaccines under investigation include Group B strep, CMV, and malaria. So hopefully one day I'll be able to talk to you about those vaccines. And then finally, I just wanted to let you finish off by saying that there are tremendous vaccine registries for inadvertent immunizations during pregnancy. And all vaccines include VAERS, the Vaccine Adverse Event Reporting System, the HPV 9-valent vaccine for Gardasil. The rubella vaccine registry has been discontinued since the 80s, but varicella and smallpox are still in effect and may be contacted for reporting of inadvertent vaccinations. And with that, I will say thank you and take any questions from the audience members. Thank you very much for your time today.
Thank you for this talk. It was really comprehensive. Can you hear me? Is that better? Yes? No? I guess my question was just around in thinking through the decision-making around the RSV vaccine versus the immunoglobulin. I don't know if you could talk about any potential benefits also to the mother during pregnancy for the vaccine and any other considerations, including cost or access.
Thank you so much. I appreciate that. So far, there hasn't been significant cost efficacy studies looking at the vaccine versus the nirsevimab. But I will just say that there is potentially the benefit of the mother also not, or the pregnant person not being infected with RSV for the vaccine. Although that wasn't one of their primary outcomes, I'm sure that it is something that they'll be looking into as we continue to move forward. And with respect to efficacy, they are of equal efficacy. So it's really a informed decision and joint decision-making process between the patient, the pregnant patient, and the physician or provider, advanced practice provider.
I'm Sandy from COSI Clinic. I actually have 3 questions. Sorry, I will ask one at a time. The RSV vaccine for pregnant women, why is it there's a temporal limitation to it? Do babies only get RSV in winter? Because with adults, we give the RSV all year.
I agree with you. That was the way that the FDA released it. And one of the other really frustrating things is that we give it until January 31st, but RSV season goes until March and April, in fact. And so there's a gap there, and we really don't have a good answer why the FDA recommended it that way, except that I think they thought that maybe if you get it at 32 weeks by the end of January, then that'll cover you for the next 2 months, basically. But it doesn't cover the rest of the patients that come after that, unfortunately, and are in the risk group. But that's how it was done. And there's not rhyme or reason to it, unfortunately. There isn't a better answer that I can give you. And in fact, I even called one of our pharmacists today, and we both thought that there's no answer to it.
So then you give all the neonates the RSV globulin?
Yes.
Shot? Yeah.
Yes, we can give that to them until April. Yes.
Okay.
So
And
the mothers, the pregnant persons who don't get the RSV vaccine after January 31st, for example, then their infants qualify for the monoclonal antibody throughout the remainder of the RSV season, which is until April.
Great, thanks. And the second question, with the Hep B series, you mentioned it was with the 3-shot brand. Has there been studies done on the 2 series Hep B?
Well, so in pregnancy, there's been a study done on an expedited 3 injection series. So it was at 0, 1, and I believe at 3 months, and it had comparable efficacy. So if someone is in a short period of time, and you know that you won't have them left over for the postpartum period, you can give them the expedited series, which is with 3 injections, and it's at 0, 1, and 3 months. And the study was done by Jean Sheffield, who's now at Johns Hopkins.
There's also I don't know the name of the Hep-F 2 series Hep B vaccine that we give all adults now instead of the 3 series because, better compliance, they get them all.
Yeah.
But
we don't have much data with that. So at this time, we're still doing the 3 series for pregnant persons.
okay, last question, promise.
Oh, no, you have great questions. Thank you.
So when you mentioned varicella exposure in pregnancy, if someone is varicella immune, they don't need to get the globulin, do they?
Absolutely. So if someone is varicella immune, they do not need to give the globulin. And if someone is varicella immune or non-immune and there is a zoster case, you do not need to give the immune globulin also if there was no direct or close contact. So for varicella zoster, it's a little bit more, the recommendation is for direct contact with the individual. So like a close household member, we would give the Varizig if they're non-immune and they have a close contact. But if it was just someone like in a clinic, for example, and in a room, you don't need to do that for someone who is varicella non-immune with zoster. But if it's non-immune and there was an infection going on, you definitely do, but not if they're non-immune, not if they're immune, excuse me.
Hi, Dr. Aziz. I'm from San Mateo Medical Center, and I just wanted to thank you so much for this very comprehensive review of the vaccines that we're presently using. And I just need to make a comment, which is the overwhelming evidence that exists in the entire world. Every country has the same data of the importance and efficacy and safety of these vaccines. And yet there is so much online mis- and disinformation. One is just mistakes and the second is intentional. And I just want to say, this information, everyone in this room needs to be an ambassador of carrying the message of the importance and safety of vaccines, because our entire society depends upon it.
I think you summed up my slides perfectly. Thank you for that beautiful summary. I really appreciate it. I couldn't have stated it better myself, and I completely agree with you. And that's why the recommendation that left out pregnant persons and children by the CDC for the COVID-19 vaccine is it really is egregious. I apologize for using that word, but it really is egregious for leaving out healthy pregnant persons, because we saw so many pregnant persons that were at severe risk during COVID-19 and that were much sicker than a non-pregnant individual at the same age and the same characteristics.
Yes, and I just want to add, one of the most poignant stories was the 34-year-old nurse in Florida, pregnant, who delivered her baby, and they both died of COVID. 34, no pre-existing conditions, none, 0. So, people I know are tired of COVID. They're tired of thinking about the pandemic. It did a lot of damage psychologically to people with isolation. But I really hope that we can, as a community in especially this area, the peninsula in California, in the San Francisco Bay Area, move together in science and reasoning and logic and keep each other safe. And the only way to do that is for all of us to be up to date on vaccines. So thank you, Dr. Aziz. You're my hero.
Thank you so much. Thank you for that beautiful and passionate message. I feel like I attended an inspiring talk right now. Thank you.
Thank you, Dr. Aziz. It was a great talk. Thank you so much.
Thank you. Goodbye. Thank you very much.